So I work a lot with suicidal clients and patients in a lot of different settings, both in the psychiatric emergency services at St. Mike, as well as in urgent care, where we'll follow up patients who were referred from that setting for a few months. I see, a broad group of outpatients, and now I've started with the DBT skills program, and I don't know if people here are familiar with dialectical behavioral therapy, but that is something that is often deployed as a treatment for people with past suicide attempts. So this is a patient group that I'm quite used to working with. I have no financial disclosures. So just an overview about how this talk will work. I'm just going to start out with clarifying some terminology, just making sure we're all aware of definitions, we're all on the same page. I'll go through some stats about suicide. Then I'll talk about assessing a suicidal patient from an evidence-based perspective, which, while making this talk, I learned was perhaps a little bit of a more elusive idea than originally I might have thought. And then just a short little bit on potential interventions. Okay, so just to start with terminology. So it's important that we consistently use well-defined terms for suicidal and ideation and behavior. It's really going to help us and help patients. I mean, as I'm sure all of you are aware, there's a lot of transfer of documents and just verbal handover in all different kinds of healthcare settings, whether you're going from a family doctor's office to an emergency room, someone who's new to the city, meeting someone's case manager. There's a lot of information that gets handed over. And it's really important that that be as clear as possible, especially in such a sensitive and important topic. So it's important that we all know what someone else means and that we don't mistake words or make assumptions. Also, when we're reading professional literature or even documents in someone's chart, if that's something that you have access to, if you're putting a document in someone's chart, you want to be able to communicate clearly. So yeah, sometimes there's a lot of times in this topic with suicidal ideation and suicide behavior, different terms are used for the same types of thoughts or behaviors. It can be misleading, it can cause misunderstandings, misapprehensions about the patients. There's also certain terms such as gesture, threat, referring to the patient as manipulative, calling a suicide attempt successful or non-successful, saying that a suicide attempt is non-serious. Not only is that not clear, and we don't really know what that means in any, one particular incident, it's potentially pejorative towards a patient, right? We don't want to think of people who commit suicide as being successful at it, right? We want to think of it maybe a different way. So we're probably going to use, in this talk, I use the word complete suicide. I think it's more neutral. And yeah, if there's any other terms that people are aware of as being something pejorative or problematic, you can ask about that. It also sometimes depends, sometimes literature from the UK uses different terminology than we do. So it's important, I think, to know what you're talking about. So what is the exact terminology also about suicide? So suicide is just briefly defined as the intentional ending of one's own life. When we talk about passive suicidal ideation, we're referring to thoughts that life is not worth living or that one would be better off dead. So this is sometimes can go into a wish to be dead, but it doesn't necessarily mean a wish to harm yourself. However, it's still a very important indicator of suicidality. Doesn't mean it's less important than what we call active suicidal ideation. And it's still worth asking about. Active suicidal thoughts are thoughts of harming oneself with the intention of dying. Specific plans, formulation of a method to die. And a suicide attempt is an action that is potentially self-injuring and performed with at least some intent to die. So that's also something that can be a little difficult to elucidate from clients if they are someone who self-harms. So because suicide and self-harm often overlap, both within, community of clients who suffer from depression or other mental illnesses, and even within the same patient who may have had issues with both of these things at different times, however, they may be completely different. So sometimes these terms are used interchangeably, self-harm attempts or suicide attempts. It's really important that we clarify which is which, especially when we're handing information over between each other and when we're working with a client, when we're trying to help them formulate goals and plans to the future. It's going to be a different set of strategies. So self-harm is an intentional and often repetitive behavior that inflicts harm on your own body. It needs to be for purposes not socially condoned, and what we mean by that is basically piercing or tattooing is not self-harm behavior. That's socially condoned behavior. It's okay to harm yourself to that purpose. That's just society. Different societies may have different ideas. Perhaps that wasn't considered to be acceptable in the past, but now we wouldn't consider that to be anything pathological. And it's without suicidal intent. So that, again, can be difficult to distinguish, especially in someone who struggles with both. So it's really important to know what to ask about, right? Like, what were you intending when, if it's something like if patients cut themselves, right? Finding out from them, what were they going for in that moment, right? What were they thinking about? Because if it's purely self-harm, you're not trying to die when you're doing it. So for some clients, it is a coping mechanism, provides them with temporary relief from their distress. So the majority of people who self-injure do not wish to die. They don't necessarily have any suicidal ideation at all. And in fact, I have plenty of people that I've worked with who have said, actually, when I self-injure, that's an attempt to live. I'm trying to kind of bring myself back, stop dissociating, or reconnect with my emotions. For me, that's a way to continue my life forward. So it's really important to not just look at the behavior, but the person's understanding of what they are doing. However, accidental death can result, right? There can be self-injury. I mean, not that it really ever goes right, but really gone wrong, and that may be misidentified as suicide. People sometimes take overdoses to self-injure, not to kill themselves. They still have a potential risk of death, right? There's a lot of different situations where that could occur. So now to just go into some stats about suicide, which, are something that maybe we're not all aware of. It was interesting for me. I was aware of some of this, but to learn some of this. So in the younger population, adolescents, 15 to 24, suicide is actually the third leading cause of death. So from that, we know that people ages 15 to 24, just by existing in that age group, are at a risk of suicide, no matter who they are. Overall, for the whole population, it's considered to be the 10th leading cause of death. Now, I think with all statistics about suicide, we have to, take them seriously. These are from good sources, the WHO and the CDC. However, it can be very difficult to document what's a suicide and what isn't on an individual basis. So we may also want to sometimes consider that they may be underreported, right? It may be a bigger problem than certain stats can let us know. In the US, approximately 40,000 die per year from suicide. Since our population is 1/10 of the US, we may want to approximate and say probably about 4,000 a year dying in Canada. 4 times that many will be hospitalized due to injury sustained while attempting suicide. So just the attempts in themselves are a serious healthcare issue. So those who complete suicide are people who use methods that are more likely to be fatal. So that just increases the likelihood that their first suicide attempt will end in death. So I had found some different stats on this, but I thought it was very important to know up to 75% of suicide deaths can occur on the first attempt. It's probably not 75, it's probably less than that, but certain studies have found that. That means that they are not preceded by, I should not have used the word successful, sorry, I caught myself out there. Incomplete attempts, let's say. So what that means is that there's plenty of people that using that piece of knowledge, okay, someone who has attempted suicide in the past has the possibility of attempting it in future. There's some people that we don't know that about. That can make them a little bit harder to predict, or we'll say impossible to predict, right? And I think that's a sobering idea for us, right? To know there's just going to be some times that it's going to be hard for us to know. For someone who chooses a very lethal method for their first attempt, there is the likelihood that they will die of it. And the vast majority of those who do attempt suicide at some point will never actually kill themselves. So the thought is somewhere between 3 to 7% of those who attempt in their lives will end up completing suicide at some point in the future. There's not really a good timeline. Once you've attempted once, you are at risk for the rest of your life. It is, the other side of that is that it's a low percentage of attempters who will ultimately, completely commit suicide. However, they are 38% more likely than a person who has never attempted to complete suicide. And I don't know, like when I was first researching these stats, it kind of could get a bit confusing. If it is confusing to anyone, let me know, because there's this huge population of people who don't attempt and do complete. Then there's the huge population of people who do attempt and don't complete. So it's not always the overlapping population, but I think it's more for us to understand who could be at high risk. So suicide attempts are much more common than a completed suicide. The rough guess would be perhaps there's one completed suicide for every 10 to 25 suicide attempts. That's not in any one individual person, that's in the population. For each individual, it's going to depend on a huge amount of other factors. About 34% of those who have suicidal ideation at some point in their lifetime will go on to make a plan. The other side of that is that 26% of those without a plan will just make an unplanned, or what we might call impulsive suicide attempt at some point in their future. So it doesn't mean that those who have suicidal ideation and no plan are at zero risk, right? There's risk on both sides. So here's a world map. So around the world, suicide's a major problem. The WHO estimates that about 1 million people per year will die this way. The rates vary greatly between regions, and there's actually a lot of interesting study about suicide in different kinds of communities, cultures, countries. Part of that may be different death certification procedures in different countries. There may be certain countries where they don't have as much of a standardized way of certifying cause of death, and they may kind of choose to not report it as a suicide for cultural or family reasons, not wanting to embarrass the person or their family. So we may not actually have a great idea as to how different countries are. There is the thought that in northern countries in Europe, there's a higher rate than in southern countries, and there's a lot of research been done into that. Some of the countries in southern Europe are considered to have more social cohesion. I read one article that gave Greece as an example. Apparently that despite some of the economic difficulties and other difficulties in Greece, there is a strong community sense there, and that is considered to be why they have a lower suicide rate than certain other countries. Because, I mean, you would think maybe, I don't know, I would have maybe assumed that some of the northern countries have really good health care, and they're really pretty good with mental health stuff there. However, there may be the burden of seasonal depression, and countries like that, there may be a lot of different issues there that contribute. Interestingly, it's the former Soviet states and China that have the highest rates of suicide, and there has been a lot of study on this. A friend of mine has done a big study on some of the suicide rates in China. It's 3 to 6% of deaths there, which is extremely high. And interestingly, China seems to be the only country where the gender rate, male and female, suicides are about equal. That's not the case in any other country or culture in the world. So just from a culturally relevant viewpoint, it may be important to know that. So methods of suicide. So access to specific methods is one of the factors that can translate a thought into an action. The danger of available methods can determine a fatal outcome. I think an interesting kind of case study in this is people here have probably heard of Sylvia Plath, who was like a famous author. She was one of the most famous authors in the 1950s, and she committed suicide in a way that was common at the time in England. Was people had gas ovens, and she used the oven to commit suicide, which was considered to be quite a common occurrence in that part of the world. However, a few years later, they changed the oven system, the way that I think people still probably used gas ovens, but it was a completely different way, and you couldn't use it to kill yourself anymore. And that form of committing, the suicide rate lowered quite a lot. So just having that access right there in your own house made people perhaps who were having a more impulsive moment, or who maybe were depressed and wouldn't motivate themselves to go out and go through a whole number of steps. It actually made them closer to the act. So there are ways in which that also is a public health issue, right? I think car emissions have been changed so that it's not as easy for people to use carbon monoxide from a car to end their lives either. So it is really important also to ask how this translates to us and what we can ask our clients to know about them. Do they have a lot of available methods to themselves, right? This can also depend different professions, right? They say, for example, physicians have a high suicide rate. Part of that is that, we have access to all the means in the world if we wanted to use it, right? Nurses too. So that can be a really important thing to know about, knowing about someone's lifestyle, their home. The availability of specific means for suicide does affect those national patterns around the world. So in the US, where, obviously it's in the news all the time about firearms in the US, they're used in half of suicides, which is a high rate. It's much less than that here in Canada. Even though people here have firearms for hunting reasons, it doesn't seem that it's used to the same degree. So in a region where more guns are kept in households, there's more risk that someone would commit suicide by gun. So that can also translate to another question. Sometimes if people tell you that they have an idea of shooting themselves, it's really important to ask, do you have a gun? Do you have access to a gun? I've had people tell me, no, I've never seen a gun. If I had one, I would use it. And then I have other people say, oh, well, I have one under my bed. In that case, actually, you can call the police and have it removed if you think that there's a risk or that it's unsafely stored. You can talk to the client about this. So this is a really important thing to know because, yeah, a gun's a very high-risk method, a firearm. Interestingly, in rural areas in developing countries, the main method of suicide is ingesting pesticides. So they're very toxic, they're easily available, a lot of farmlands, and they're poorly stored. So these are probably pesticides that we don't have, that have been banned in Canada and the States for a long time because they are toxic, and people generally maybe want to have more organic food and less toxic food, but that's not the standard in every country. And in countries where more people make a living farming or would have access to that, they would have the ability to use it. So up to 30% of global suicides may involve ingesting pesticides. So I thought that was important to know. So if you ever do, meet a client who may have some kind of availability of this, it's good to ask about. I just found a picture of some pesticides that are not available here that potentially could be fatal if ingested. So what we call high-risk methods are those that are most violent and immediately lethal. So the highest case fatality, i.e. the most percentage that you would be likely to die, are firearms, which we mentioned, and also hanging. So that's, if someone has attempted to hang themselves, asphyxiate themselves, that's a very, concerning method. I think, it was in the news a few months ago that when Robin Williams died, unfortunately, that was the method that he chose. So what's interestingly, when we talk about the suicide rate being higher for men than for women, it's attributed not 100%, but in a large way, because males are at greater risk of choosing highly lethal suicide methods. There's a lot of reasons and hypotheses behind that. I mean, they may have more access to firearms. There's kind of gender roles and ideas that go into every part of life, even choosing a method to kill yourself. So that's an influence. Females, although females are the ones to attempt suicide much more often, are at less risk method-wise. Females mostly choose self-poisoning, which could mean an overdose attempt, right? So when we talk about self-poisoning in the context of North America, we're not as much talking about those pesticides. We're usually talking about people poisoning themselves with medications, either prescriptions, things they buy over the counter, things that they take from someone else. And for a lot of reasons, that's not considered to be as likely to be lethal. So how does this translate to us? So being aware here that, I'm talking to a different audience of healthcare providers and allies. Everyone has their own profession. Everyone has their own, they may have an adherence. I'm part of a college of physician and I have guidelines according to that. If you're part of the College of Nurses, you have your own set, social work, whatever. The important that we all have in common that we have a standard of care of our profession and that we're all clinicians who work with clients and patients. It is not the standard of care for any profession in the world that a clinician is able to prevent a suicide, okay? No one expects the impossible. It is the standard of care that the clinician can make a competent risk assessment and does whatever a reasonable clinician of their profession, of their regulatory body, would do to prevent a suicide. So what that means is you're expected to assess the risk of suicide in each patient or client at any time when a person of similar training would find it prudent, aka reasonable, safe, to do so. So as long as that's done, that's communicated and documented in the way that's, correct for your profession, you have fulfilled your standard of care. And I think this is important to mention because we often put a lot of pressure on ourselves, especially those who work with high-risk clients who are more likely to get themselves into this situation. It's really scary, right? In medicine, we think about this a lot. We're scared of getting sued. We're scared of people blaming us. That may be. It doesn't mean that we have the ability, that it's just not possible to prevent every suicide or to really have a good idea of everyone who's going to do it. It is reasonable for us to use the knowledge that we have, some of the things we're talking about today, our past experience and training, to communicate that with others, to write it down, to be thorough, to be communicative, and to have a good practice and our own set of ways of doing that. So here's a clinician and patient talking. So, I really want to emphasize that it's a difficult task to assess someone's level of suicide risk. It's actually an impossible task, but, for the level that we want to get to, it's quite difficult. Suicide's a rare and complex phenomenon. It's so rare, although we talk about how it's common, anything that is not, a major, very common circumstance is considered rare. It's also so complicated. It's so individual. It's so dependent on what a person is thinking inside, what they're experiencing, all the different things that are going on for them at that moment, that it's extremely complicated. It's a lot easier to figure out, the risk of someone's having a heart attack if they have high cholesterol. It's still not possible to totally know. You could know someone's cholesterol level. You could know, okay, that means in 20 years they have so much % chance of having a heart attack. You don't know which one is going to be the one to have the heart attack and which isn't. So this is even more so. There's about an infinite number of factors, not all of which we have access to, right? So it's associated with so many biological, physiological, social factors. Not only does it require a diligent assessment, it often requires a multidisciplinary assessment. It requires documentation. It requires follow-up with the person. We can't always provide all of that, right? It's just about applying what we know in that case. So as healthcare providers, this is an extra difficult thing because typically we're counting on a collaborative partnership with our patients or our clients in pursuit of common goals. So typically we're looking for goals like improving someone's health and well-being, improving their happiness, giving them a longer life, a more fulfilling life. This is a kind of a different situation, right? If someone is seriously considering suicide, we can't always rely on them to be co-invested with us, on them living and receiving care and wanting the same things that we assume that every client would want, right? So, if someone is determined to end their lives, that may stop them from sharing suicidal thoughts with any care practitioners, right? So there's a lot of different ways that we have to look at different factors. So are people here familiar with sad person scale? Has anyone seen or heard of that before? This is something that I think is disseminated in the literature a lot. We teach it to medical students all the time. I want to be clear when I give all of this research that because of the factors that I've explained, the rareness of suicide, the multifactorialness of it, the, individual sort of dynamic factors about what someone says, how they communicate, how they interact with the healthcare service, if they interact with the healthcare service at all, there's not a lot of evidence for any specific factor, okay? So this isn't as easy as in a lot of medical issues, a lot of healthcare issues. We say, okay, well, all the evidence says, if you are depressed, you have to exercise, right? If you are depressed, take an antidepressant, right? Because 30% of people will improve their depression with that. We don't have numbers like this. So that's why it's much more of a bit of an art, but for you to have as many tools as possible. This scale doesn't add up. Someone could have every single item on the scale and never, not be someone who's ever going to attempt or complete suicide. Also, someone cannot be, particularly affiliated with any of the items on the scale, and they may complete suicide, right? But these are just ways to orient your thinking, which is kind of what I want you to use this information for. So sex, women attempt suicide 3 times more than men. But men complete 3 times more than women. I also wanted to bring attention to the fact that any person who's trans, whether they're a trans male or trans female, has a high risk of having attempted suicide. Up to 40% of people who are identified as trans have attempted suicide at some point. So it's very important to be aware of when we work with trans clients that they may be at higher risk. So the highest risk groups for age, adolescents under 19. So yeah, those who are in that 15 to 24 age group, and men over 45. Or especially in the past, those were considered to be the traditional, men over 45 were considered to be the traditional people who completed suicide. Depression. So up to 5% of patients who are hospitalized for depression may eventually commit suicide. Having a previous attempt. So like I said, it doesn't diminish with time. You could have attempted 40 years ago. Your risk is still above normal. Ethanol abuse, so that's, you can see they kind of try to fit, usually we call ethanol alcohol, but because it doesn't fit in the mnemonic, we call it ethanol here. Up to 5 to 15% of patients with a history of alcohol abuse can go on to commit suicide. So that's a 60 to 120 times more risk than the general population that does not have an alcohol abuse disorder. So again, this is an example of trying to fit something into the mnemonic. Rational thinking loss, that's not what we call psychosis, but they just mean psychosis. There just was another P. So if someone is psychotic, if they are not in touch with reality, and when we talk about psychosis, we often talk about things like auditory hallucinations, hearing voices, having paranoid delusions, having grandiose or religious delusions. There's another aspect of psychosis that's a little harder to assess, what we call negative symptoms of psychosis. That looks more like depression. That's more like a bit of a cognitive loss, a motivation loss. Those are much more subtle symptoms of psychosis. However, they can still contribute to a risk. Someone can have treatment for psychosis that helps them with their positive symptoms. They may not have any more auditory hallucinations. They may not hear voices. They still may have a lot of negative symptoms. Unfortunately, those are tough to treat. That low motivation, low energy, low engagement with your emotions, that can contribute potentially to a suicide risk. Social support's lacking. So social isolation from friends, relatives, or the community increases the possibility. I think the kind of first book on suicide was written in the 1800s. It's a famous book in sociology by Durkheim. So some people might have studied that book in university. And he talked a lot about people moving to the cities at that time and not being in their community anymore and feeling what he called anomie or isolation, not being one of the community. And that in his view, was a cause of the increase in suicide at that time. Organized plan. So those who have a specific plan outlining a lethal available method are at increased risk. Like I've said, there's also all the impulsivity out there. So don't think that people aren't at an increased risk just because they don't have an organized plan, but be cognizant of that organized plan. No spouse, okay? So in the older population, those who have lost their spouse are at a higher rate. Sickness. So the presence of a chronic or severe illness can increase the risk. So thinking of all this information, to me, it's almost like a maze. Like there's so many factors. It's so hard to know with any individual. Like, how can we arm ourselves, right? So I just really want to make sure that if you feel confused or overwhelmed by all this information, I often do, right? Just think back to these principles and know the different factors, get to know the person you're working with, who they are, and what has changed for them, right? So if you ever feel like you're in a maze, don't worry, that's what this is like. It's what it's like for the person you're working with, and it's what it's like for you. Work with your colleagues, talk to them, get help in terms of understanding, and that'll help it clear things up a little. So when we're assessing a specific patient, we want to look at the risk and protective factors. Those are hard to know because they can vary with age and gender. They can occur in combination, a lot or a few, and they change over time. So most clinically useful predictors of suicide are psychiatric risk factors. So we've talked about, or we will talk about, demographic risk factors. So these are psychiatric risk factors, are pretty individual, especially if there's other risk factors, like general risk factors for that person, like being in one of those age groups, being in one of those communities. Depression, substance use disorders, and or other mental health problems are present in 90% or more of patients who complete suicide. And people often ask, well, what about the other 10%? I don't think that's very well known. It is thought that those in the other 10%, even if they don't have a diagnosis, have either symptoms or personality characteristics that are more similar to those on the 90% end of the spectrum. They may never have gone for any kind of treatment and never have been identified that way. So major depressive disorder, it's an important risk factor. It's also a very common mental health disorder. Up to 20 to 30% of people will have a diagnosis of a major depressive episode in their lifespan, right? So this is a huge chunk of the population. So those who have mood disorders, so that includes bipolar disorder, right? There's also a risk for suicide there, who attempt or commit suicide will primarily do so during a major depressive episode. So if you've had a past diagnosis of major depressive disorder, you're doing fine now, you're in remission, you don't have a lot of symptoms of depression, you're not necessarily at higher risk at that moment, right? It has to be during the episode. So some of the risks there are the severity of the depressive symptoms, particularly hopelessness and guilt are considered red flags. Also for those who have either bipolar disorder and they're having what we call a mixed episode where you have manic and depressive symptoms at the same time, or those who have what we call an agitated depression. It's a depression where you can't sleep, you really feel activated. It's almost like being manic, even if you don't have that bipolar disorder, but you're not happy manic, you're not excited about the things you're doing, you're still suffering just as much. That's a higher risk, because this is a depressed person with energy, right? One of the things that's kind of paradoxical about depression is some people may have very strong suicidal ideation and depression, but their motivation and their energy is low. So they're not getting it together to go and make that plan, get those means, do the steps forward to actually complete suicide. However, if you have a lot of energy and you can't sleep, that just may be something you're capable of doing in that state. So this is alcohol. So substance abuse is a major factor. Like I said before, alcohol abuse and dependence is strongly associated with suicidality, so with suicidal thinking and behavior. 1/3 at least of suicides occur while patient is under the influence of alcohol or drugs. The risk of suicide will increase with the severity of your alcohol use disorder, the presence of aggression. If you're someone who gets into fights, hurts other people while drunk, you may be someone who hurts yourself. Impulsivity, obviously drinking in of itself increases impulsivity. That's one of the reasons people like to do it. However, it removes judgment, right? It's part of that rational thinking loss in the sad person scale. Also, if it's in combination, if someone is drinking more because of a depressive episode or a stressful life event, you want to keep an eye on them. So other psychiatric conditions. So I've talked about depression, bipolar, schizophrenia, also like the psychosis there, it can increase your risk. So there's a high risk among individuals who suffer from eating disorders, particularly anorexia. Anorexia is actually considered one of the most lethal conditions in psychiatry. They have a higher risk of suicide. They additionally can die by physical means. So this is something to be aware of. 1/3 of individuals who complete suicide also suffer from a personality disorder. So borderline and antisocial personality disorders are most common. Part of that is that both of those conditions include impulsive behaviors. That's kind of a stereotype about borderline personality disorder. Lots of clients with borderline personality disorder will never self-harm or attempt suicide, but it is a feature for many. Up to 10% of people with borderline personality disorder may die of suicide. So it's really important, especially if you're getting burnt out with a client who's borderline. I'll talk a little bit about chronically suicidal ideation, but if they are always suicidal, if they've made frequent attempts, it can be really hard, especially in the emergency room, for us to know, well, how is this different? They've made so many attempts. They're attempting every week. What's different now? How do we know if they're at higher risk? It's really important to take that into account and know what happened in the past, and also take each individual episode seriously and evaluate it in of itself, because there can always be one that has more risk factors than another. So also the majority of these individuals will have what we call comorbid depressive and or substance use symptoms. That means that they have more than one diagnosis. So if you have depression and or substance use on board and anorexia and a borderline personality disorder, then you're someone who, would be considered to be on the higher end of risk. So these are demographic factors. So I would also think of these as like static factors. These are factors to be aware of, but we cannot do anything to change this for any of our clients. We just need to know and identify them. So these are things that are associated with a higher rate of suicide. Like I've said before, having male sex, being an adolescent or an older adult, or being a member of an indigenous population in Canada, such as in Canada, US, Australia, New Zealand. So if you're First Nations, there's a higher population risk. Demographic factors that are associated with suicide attempts, not necessarily as much completed suicide, is being female, unmarried, being younger, having a lower educational attainment, and unemployment. So those are also, some of those correlate with risks for depression. It may be that this is someone who's had a more difficult life if they've had a lower educational attainment or unemployment. They may not have attained those things because they've been depressed for so long. So there's a lot of different ways that that can happen. So social risk factors. So stressful life events can often precede suicide. Those who have had physical or sexual abuse in their childhood are at higher risk. And especially in the elderly, that social isolation and lack of support is more relevant even. So yeah, these can be, when we talk about social risk factors, we're talking about things that are interpersonal or sometimes health related. So problems with employment, family conflict, or what we call a family discord, and personal illness, physical illness. So with all this information, how are we to think of, these seemingly dozens of risk factors and how it applies to anyone? Well, we want to be thinking about what are the individual warning signs. So warning signs are risk factors, but we call them proximal rather than distal in terms of their relationship to suicidal behavior. Basically what that means is they're close at hand. Usually, a lot of those risk factors that I've talked about are calculated on an extended time frame, looking over a whole population, looking over a person's whole life. That's great for population studies, but it doesn't tell us about one individual and what they're doing right now. So the warning signs are changes or new information that we get that's going to bring us perhaps closer to the emergence of behavior. So these are observable signs and express symptoms that can elevate their short-term risk, relates to current functioning, and these are episodic and variable. This isn't one of those unchanging things like male sex. So just kind of again, this is just sort of a list to look at. The American Association of Suicidology identified some of these as needing immediate attention. Immediate attention means looking at, asking about it. It doesn't mean this person needs hospitalization, but it means find out more. If someone's threatening suicide, looking at ways to kill themselves, seeking access. I often ask people if they've been looking online because I think there's internet forums that tell people about how to access means and how to use them. So I get pretty concerned if somebody tells me they've been looking at that. Talking about death, dying, or suicide. So again, these are pertinent. These are not necessarily like, there's not going to be an evidence like 1% of people who talk about this are going to do it. It's just keep your eyes out for things like hopelessness, rage and anger, recklessness, feeling trapped, alcohol or drug use, social withdrawal, so a change in their social connection, anxiety and agitation, insomnia or hypersomnia, mood changes, lack of reasons for living, or lack of purpose in life. So a lot of these overlap with some of our DSM symptoms of things like depression, anxiety disorder. It's also important to know that these are things like if these are recent changes. If you've known someone and they've always been like this, that's one thing. If you meet a client and all of a sudden they're hopeless, all of a sudden they're using, all of a sudden they're agitated, keep an eye on that, right? Get to know that person and what's different and what's, typical for them. So factors that can increase impulsivity, so using or withdrawing from alcohol. So even if someone makes a positive decision to stop drinking or using drugs, that's a physically and emotionally stressful period. They may be at higher risk for impulsivity at that point. Acute psychosis, so command auditory hallucinations, those are hearing voices that tell you to do something to hurt yourself or someone else. So that's something that we, in the emergency room, always ask people. Persecutory delusions, those are delusions that people are following you or want to hurt you. Reduced cognitive function, so that can be caused by a head injury, dementia, lots of different causes can reduce your cognitive function. You can't think as well, you can't think through the consequences. Agitation and mania can make you more impulsive. So imminence, so this is what we get most concerned about, right? Especially in the emergency room if I'll talk a little bit about issuing forms. We can only issue a form. Someone can have a long-term risk of suicide. We cannot force them to stay in hospital. We need to look for that imminent risk. So indicators can be those cogent, so highly thought out suicidal plans, higher levels of hopelessness, really feeling like there's no point in going forward, alcohol misuse, and easy access. So again, a lot of this is repetitive, but it's good to know timeline-wise what's going on for the patient right now. So what can we ask? How can we ask about these things? So questions that can be good to ask. Do you have any hope for the future? So people may say no, but then when you engage them in conversation, they may talk about something next month that they're looking forward to, something that they've signed up for, going back to school, or even, having a specialist's appointment. So we can take that as some indication of hope for the future. They're not saying I'm never doing anything ever. So think about this in a lot of different ways. Do you have thoughts of death, of your own death? If you died in your sleep, would that be all right with you? That's an indicator of the passive suicidal ideation. Have you ever thought about killing yourself? Have you formulated a plan? It's also really important to know what stops a person from killing themselves, right? People know how to do it, right? But they're not. I mean, if they're talking to you, they haven't done it, right? So what has stopped them, right? So it's really important, and don't be afraid to ask that. These are really good things to know, and it's not going to push someone in a negative direction. They're going to feel more understood. So information to gather. Determine the level of detail in the patient's plan. So you can also clarify their investment. Is this something you really want to do? I ask people often, is there only a specific circumstance, right? Some people said, well, if my wife left me, then I would do it, right? And find out, is that something that's going to happen, or is that unlikely, right? So get a sense of how invested they are in that plan. Is it only on a small condition, or are they definitely going to do it? People should be asked to articulate convincing reasons for living, right? If they have this plan and they're saying, well, I wouldn't do it, it's like, well, why wouldn't you, right? And then they may be able to come up like, I would never want to disappoint my mother that way, or, I want to get better, things like that. Poor impulse control. So again, we've talked about this. Have they attempted suicide when they felt this way in the past? It's good to ask them, at your worst point in your life, how did you respond? What did you do? If they say, well, I overdosed and I, attempted suicide, that's different than if they said, it was really horrible, but I went to my family doctor and I got through it, right? So get an idea of what happened in the very worst point in their life, and that will give you an idea of their level of, how they cope. So when you're working with depressed patients, show empathy, ask open-ended questions, be a good listener. I know it's hard, we don't always have a lot of time, but reinforce their efforts to work through and understand their feelings. Explain to them that a depressed mood impacts their perception. It makes the world seem like a bleak place. They don't have as much energy to deal with things. They may not feel like getting out of the house and going to access their resources. Help them problem solve around that. They have compromised judgment if they're thinking in a depressed way. It's not the right time to make huge decisions, right? They may need treatment for depression. Sorry, I'm trying to go quickly to make sure we have enough time. So there's a lot of reasons why the patient won't disclose their suicidal ideas to you. You can have a look at these, but basically they may be impulsive and they may not actually have thought about it before they try it. They may not want you to stop them, right? And that's very hard. If we've had, cases where someone did complete suicide. They had been asked in the entirely appropriate way, and they said no because they didn't want to be stopped, right? There is not a lot we can do about that other than forming a strong relationship with the person we're working with. They may be ashamed. They may think it's immoral. They may not want to be brought into hospital. They may be so hopeless they don't think that there's any point of saying. And they may be what we call alexithymic, so that's someone who can't read their own emotions. So that's being illiterate about your own emotions. They may not know how depressed they are. And I've certainly actually encountered surprising amount of people who are high functioning in so many other ways and had no idea that they were extremely depressed until they found themselves in a really impulsive and unsafe situation. So get collateral, right? If you have those concerns that this is someone high risk who might wish to take their own life but isn't going to tell you, see if there's other information sources, a caseworker, a family member, if they're agreeable to have you talk to that person. Anyone else who can give you an idea what's different for them right now. What are you worried about? So I just put this up. It's just on your slides. I just found this was kind of a flow chart. It specifically mentions patients with HIV, but basically it kind of gives you some questions, things to find out about, and then how to proceed next. But this is kind of in keeping with what we've been talking about. This is not something you need to memorize. It just kind of encapsulates some of the information. So I know a lot of people here work with Casey House, so I wanted to mention there is a lot of work, research done on people with HIV and AIDS. Someone who has HIV has an elevated risk of suicide, 3 times 5 more for men, almost 6 times more for women, and up to 1 in 5 patients with HIV report suicidal ideation in the last week. There's a lot of reasons why. Not all medical diseases have that same level of increased risk. You know, some of the things we're all familiar with in terms of HIV, lack of a cure, stigma, side effects of medication, discrimination, can make it harder to live even if you are getting treatment and, you know, are not in a physically compromised position. Before the introduction of heart treatment, the suicide risk with HIV was much higher. Actually, in the early 90s in New York, 9% of suicide victims were HIV positive. It's much lower now. And interestingly, the longer amount of time away from your diagnosis, the lower your risk is. So if you just found out, you're at higher risk than if you've been living with this for 10 years. So I think it's important to mention chronic suicidal ideation. I work with a lot of people who tell me they've been suicidal their whole lives. Maybe they've had a bit of a break from it, but it's an everyday thing from them. And that's really hard as a clinician to know, okay, well, what do I do? How do I help them, right? So that can be a feature of different personality disorders, often borderline or antisocial personality. It can be part of a mental health disorder such as schizophrenia. So make sure that with patients like this or clients like this, that there is a tight communication between their healthcare providers, anyone else who works with them. They may have chronic suicidal ideation and then periods where it's more severe. That may be a period of crisis that they may benefit from some treatment or hospitalization. You're not going to keep someone hospitalized as long as they have suicidal ideation because that might be forever for them. But there may be periods that are more of a breakthrough. I've talked before about how it can be a coping strategy for patients with a chronic mental illness. Just the idea, well, if things get so bad, I can get out of this, right? And that's kind of paradoxical, right? But knowing that there may be relief or a way out can actually help people get through, and it may not translate to them ever acting. Maybe also a bit of an attempt to gain a sense of control over their lives that feel uncontrollable. So again, I've talked about chronic and repetitive self-injury behaviors may or may not, you have to find out, are they associated with the suicidal intent? Or is this just a way of expressing anger, a way of getting relief? Find out, because it's very different, and you're going to go about it in different ways. So among medically ill patients who wish for a hastened death, who wish to die quicker, that can happen with more advanced disease, they may ask for help in ending their lives. This is really important to assess them for depression. They may also have depression on top of their disease. They may not. It's really important to get a sense of mental health-wise what's going on with them, because most people who have a chronic, even a very severe mental health problem, do not necessarily wish to die. So it's important to get a context. Is there something reversible? Could we help them with their depression? Are they having a pain control problem? What could we do for them? So this is just a little picture, I thought, of social cohesion. So it's a family that's protecting each other. So it's important also not just to look at all these risk factors, but our protective factors, perceptions of social and family support. If people feel close with their families, if they feel close with their friends, they're a lot less likely to do it. Even if they feel like it, they say, I wouldn't want them to find me. I wouldn't want their lives to be ruined. It's really good to encourage that kind of talk, right? To get someone in touch with what they wouldn't want as a consequence. Some people have spirituality, they have religious beliefs or moral objections to suicide. That can reduce their probability. So finding out their reasons for living, do they have a purpose in life? Is there something they want to accomplish? Do they want to avoid hurting their loved ones? And there are, positive ways to translate that. And that's just a repetition. So these are all, it's important to find those out as well. So what to do when you're faced with a client who you're really worried is at a higher risk than ever, and how do you go about that? So first of all, talk to them about your concerns, talk to your colleagues. The level of care that you and the healthcare system should provide should match with the severity and the imminence of their thoughts and behaviors. Emergency room evaluation and possible hospitalization might be indicated for patients at high risk. So that's why we have the emergency room open all the time. We do a lot of assessments there. If you ever feel that this is an extremely high risk time for the patient, you don't think it's a good idea for them to go home or be on their own, right? This seems like a different, way than you usually see them. Then you can bring them into the emerge. If it's a little less imminent, bring them into their family doctor or someone else who knows them. Get some consultation that way. But the emergency room is always there. Unfortunately, although they may be hospitalized, hospitalization itself doesn't prevent suicide. The underlying problem, the depression or whatever else is going on in their lives that may be contributing, needs to be addressed. Especially in the last 20 years, as the healthcare system has gone in a way against hospitalizing people, inpatient stays are very short, and a short inpatient stay is then associated with a high risk of suicide upon discharge. So it doesn't mean that hospitalizing them is going to necessarily, it's a complicated thing, right? It may reduce certain risk factors and introduce others. A lot of patients or people who commit suicide have seen their family doctor, have seen a healthcare worker within the last couple of months, right? So it's important to keep them as connected as possible, but it doesn't mean, it's not an insurance against it. So here I just put a picture of the hospital. So what happens next? Form 1, I know I don't have a lot of time, I want to quickly go over. So the Form 1 is up to 3 days of involuntary treatment. That has to be issued by a doctor who's seen the patient within the last 7 days. Could be their family doctor, doesn't need to be a psychiatrist, could be the emergency room doctor. So if a family doctor saw them on Monday and you find something else out that they didn't know, they've disclosed to you, okay, I'm going to do this, I've gotten a gun, whatever, you can contact the family doctor, they can issue a Form 1. Then the police has to pick up the patient and bring them to the emergency room. The clock starts ticking on the 72 hours once they walk into the hospital and have seen the doctor there. There's the Form 2, which may be more relevant to people here. That can be pursued by anybody, a family member, a caseworker, any non-physician person, via the justice of the peace. So if you have reasonable expectation that this is a very high-risk time, you can contact a justice of the peace. You talk about it with them. They may issue a Form 2. Form 2 is not the same as the same one. It just requires the person to go to the emergency room. There they get evaluated, and the doctor will decide if there's a Form 1 or not. So it doesn't guarantee a Form 1, but it does guarantee that they will be seen by a doctor. So that may translate eventually to hospitalization, and outpatient treatment is probably going to be the next step. So yeah, I mentioned this admission to hospital. Unfortunately, the shorter an inpatient stay, it can sometimes be associated with a risk of suicide after discharge. So what we want to try to prevent in that is that the patient doesn't have poor medication compliance, that they don't discharge themselves against medical advice, that there isn't a follow-up for them after. It's the follow-up care that's going to be really important to keep them connected. So, again, I think what's important here is making a crisis plan is a really important part of outpatient treatment that we can all be involved in. So everyone, if you're working with a patient who suffers from suicidal ideation, you may want to work with them on an accessible written safety plan that includes their own warning signs, get them to tell you how they know they're in a more impulsive state, how things are getting worse for them. And what steps they need to do, reminders for them if they can't think straight in that moment. This is kind of something people work on often in DBT. What are some reminders of how they can regulate their emotions, who they can call for support, steps to get support in that crisis. If you're working with someone, you want to role play certain steps so that they actually can have it more accessible in that time when they can't think, and ensure that it matches their skill and competency level, right? So if it's someone who you've never seen act in a really skillful way and call everybody and, do something healthy for themselves, don't put that in their crisis plan, right? Make it realistic as to what you think they can achieve to help continue their lives. Then just other medication, I'll talk about that in a moment. So there's also the idea of safety contracts, which I don't know if you're familiar with. They're used in a variety of clinical settings. They're actually not recommended. So contracting for safety, making the person sign that they're not going to harm themselves, doesn't help statistically, unfortunately. And one of the reasons why is because it's thought that perhaps people do that and then they don't assess for suicide quite as deeply because they think that that's going to keep them safe. So having a verbal idea with the patient, like, having that crisis plan, what will you do if you feel this way? Making an appointment with them the next day or, as short as you can. I often can't do it the next day, but telling them you'll call them the next day, figuring out close contact is really helpful, right? But especially if you don't know someone very well, getting them to sign a contract, there's not a lot of pull there for them. It doesn't really work. So yeah, medication wise, again, so this is people maybe on antidepressants, It's a first-line treatment for major depressant. It reduces suicide rates. There was some concern in the past that it may increase levels of suicide, and that actually led to a lower prescription of medication. They don't really know why that was thought. It may be potentially because when people who are depressed take antidepressants, they may get an increase in energy before they get the increase in mood. And there may have been a few people that increase in energy before their mood got better led them to attempt. However, when that risk was put out and less people were prescribed antidepressants, the suicide rate went up for depressed patients. So it's, again, really important to know on a case-by-case basis. If someone is starting a new antidepressant, they should have frequent appointments with their doctor or nurse to check in about how they're doing, right, if that's going to be a higher risk time for them. There's also, again, lithium is considered maybe to have one of the only medications that lowers the risk of suicide specifically. So numbers to call, you're probably familiar with these numbers to clients that you can disseminate. The Distress Center, there's specific ones for seniors, Progress Place, withdrawal management if substance abuse is a big part of things, Gerstein crisis line. A lot of people like having someone to talk to or a place to go there. And then just some research that I used. Okay, thank you.